Welcome to the Deep Dive. Today we're cutting through the complexity to bring you the essential insights from the Society for Vascular Surgery's latest clinical practice guidelines on popliteal artery aneurysms, known as PAAs. We've taken a really close look into the panel's review of the current world literature, and our mission really is to distill these recommendations into actionable knowledge for your practice.
Exactly. And these guidelines, they're a much-needed resource, honestly. They offer evidence-based clarity for clinicians dealing with, well, everything from patient screening, intervention indications, repair strategies, and also the critical follow-up of both asymptomatic and symptomatic PAAs. And that includes those tough cases presenting with acute limb ischemia.
So we'll explore the definition, the natural history of popliteal artery aneurysms, how they're diagnosed, and then really unpack the 7 core guidelines for managing them.
That's the plan.
What's interesting to me is how these guidelines help us make those, nuanced decisions. When to intervene, choosing between open and endovascular repair.
Big decisions.
Yeah, stratifying urgent care for acute limb ischemia, setting up that essential long-term surveillance. Okay, so let's unpack this. What exactly are popliteal artery aneurysms, and why are they such a significant concern in vascular surgery?
Okay. So popliteal artery aneurysms, or PAAs, are basically aneurysms that occur outside the aortoiliac system or the brain. And they are, interestingly, the most common peripheral arterial aneurysms.
Really? Most common?
Yeah, they account for about 70% of all peripheral arterial aneurysms. You'll primarily see them in men, something like 95% of cases.
Wow.
And typically in their 6th and 7th decades of life.
So we're talking about a very specific and, it sounds like, relatively common peripheral aneurysm then. How do we define one, structurally? And what's their natural progression if left untreated?
Right. So the popliteal artery itself, it starts where the superficial femoral artery comes out of the adductor hiatus, runs behind the knee. A normal one measures around, say, 5 to 9 millimeters in diameter. It's considered aneurysmal when its diameter goes over 15 millimeters, or when it's 1.5 times larger than its normal diameter.
Got it. 15 millimeters or 1.5 times.
Exactly. And understanding its natural history is, well, it's crucial, because while many PAAs are asymptomatic when you find them, maybe 40% are found instantly. The risk of complications is pretty substantial. Up to 68% might develop complications over their lifetime.
68%, that's high.
It is. And these complications often lead to acute or chronic limb ischemia, usually from distal embolism or aneurysm thrombosis.
So throwing clots or clotting off entirely.
Precisely. And think about it. A thrombosed PAA can lead to really severe acute limb ischemia because the collateral circulation might be compromised. We've seen early amputation rates as high as 14% in some reviews for those cases.
14% amputation.
Yeah.
That's significant.
It really is. Rupture is rare, thankfully, but you can also get compressive symptoms, venous congestion, neuropathy, though they're very uncommon.
Okay, given that pretty significant complication risk, how do we confidently diagnose these? And what's sort of initial approach before we even think about intervention?
Well, you absolutely need confirmatory imaging. Physical exam alone, it's just not sensitive enough.
Right.
Duplex ultrasound, or DUS, is highly sensitive and specific. Its accuracy approaches 100%, actually.
So DUS is the go-to first step?
Often, yes. Then CT angiography, CTA, and MR angiography, MRA, are invaluable for mapping the aneurysm's full extent, proximal and distal ends.
Planning the repair.
Exactly, assessing inflow and outflow, planning the repair. Catheter-directed digital subtraction angiography, DSA, that's usually reserved for acute limb ischemia where you might consider thrombolysis, or for concurrent endovascular repair.
Okay, and what about medical management? Anything specific for PAAs?
Well, specific PAA studies are limited, unfortunately, so we generally apply the risk modification strategies we use for atherosclerotic occlusive disease.
Standard stuff then.
Yeah.
Smoking cessation, lipids.
Exactly. Smoking cessation, managing hypertension, hyperlipidemia, diabetes. It is worth noting, though, that statins and antiplatelet agents haven't definitively been shown to alter the natural history of the PAAs themselves.
Interesting. So risk factors matter, but maybe not directly for the aneurysm growth itself based on current evidence.
That seems to be the case, yeah.
It's clear that early detection and just understanding the potential for these nasty complications are really paramount. So for you clinicians managing a new PAA patient, what's the first most crucial screening step the guidelines really emphasize?
Right. The first strong directive, and this is a grade 1B recommendation, is this. If a patient presents with a popliteal artery aneurysm, you must screen them.
Must screen?
Yes, for both a contralateral popliteal artery aneurysm and an abdominal aortic aneurysm, or AAA.
Both legs and the aorta. Why such a strong emphasis there?
Because the coincidence rate is incredibly high. 2 separate reviews showed really similar numbers, 48 to 50% for contralateral PAAs.
Wow, half of them.
Yeah, almost half, and 36 to 38% for associated AAAs. So screening the other leg in the abdomen, preferably using duplex ultrasound, is recommended, and repeated every 5 years.
Every 5 years, okay.
It's really about catching these other potentially life or limb-threatening aneurysms early on.
Okay, let's put this into a real-world context then.
Mhm.
Imagine a 68-year-old male comes in for a routine physical. You palpate a pulsatile mass in his right popliteal area. Duplex ultrasound confirms it a 22-millimeter right popliteal artery aneurysm, and it has mural thrombus. He's asymptomatic otherwise.
Okay.
What's the immediate, most appropriate screening recommendation for him based on what you just said?
Right. So for this patient, the immediate recommendation following that grade 1B guideline is to screen him for both a contralateral PAA and an abdominal aortic aneurysm,
Okay.
preferably with duplex ultrasound, and then plan to repeat that screening every 5 years. It's driven directly by that high coincidence rate we just talked about.
Makes perfect sense for initial detection and broader risk assessment. Okay, now let's move into a really critical area. Deciding when to intervene on an asymptomatic PAA. What's the consensus from the guidelines on size thresholds and maybe other factors?
Yeah, this is where the guidelines offer some really crucial clarity. For asymptomatic PAAs, the core recommendation, and this is another strong one, grade 1B, is that patients with an aneurysm 20 millimeters or greater in diameter.
20 millimeters.
20 millimeters or larger, yes. They should undergo repair. The main goal here is to reduce the risk of those thromboembolic complications and ultimately limb loss.
Because symptomatic ones are usually bigger than that anyway.
Generally, yes. Symptomatic PAAs typically exceed that size, so intervening at 20 millimeters is seen as a proactive step.
Okay, 20 millimeters seems to be the key cutoff for elective repair. But are there situations where you might hold off, maybe defer intervention, perhaps for higher risk patients?
Absolutely. The guidelines do acknowledge that nuance. For, let's say, selected patients who are at higher clinical risk, there's a weaker recommendation, grade 2C,
Grade 2C, okay.
that allows deferral of repair until the PA reaches 30 millimeters or greater. This is especially considered if there's no mural thrombus present.
30 millimeters, but no thrombus.
Right. And the rationale is that we know elective intervention consistently gives superior limb salvage outcomes compared to waiting for an emergency.
Makes sense. Avoid the emergency if possible.
Exactly. There was a study, for instance, following patients non-operatively. Those who became symptomatic almost always had at least one key risk factor present beforehand.
Which were?
Size over 20 millimeters, the presence of thrombus, or poor tibial runoff. Those 3 things. If one of those was present, they were much more likely to become symptomatic.
So those factors strongly support intervening earlier, even electively.
They really do. They help identify the higher risk asymptomatic patients.
Okay, what about those smaller aneurysms then? Under 20 millimeters?
Yeah.
Is there ever a scenario where we'd consider intervening on those? They seem below the main threshold.
That's a really critical question. And yes, there is a scenario. The guidelines suggest, again, this is a grade 2C recommendation, so less strong.
Okay, suggest.
That for PAAs less than 20 millimeters, if you see thrombus and there's either clinical suspicion of embolism, like the classic blue toe syndrome, or if imaging shows poor distal runoff.
So thrombus plus something else concerning.
Precisely. Thrombus plus evidence of trouble downstream. In that situation, repair should be considered even below 20 millimeters.
Why is that? Is size not the main driver of clots?
Well, it highlights that size isn't the sole determinant of risk. There's actually evidence. One retrospective series found that patients with smaller PAAs, average 22 millimeters, had a greater incidence of thrombotic complications than those with larger ones, averaging 28 millimeters in that study.
Huh, that's counterintuitive.
It is a bit. And most of those smaller ones, 64%, were partially thrombosed. So while thrombus is common, maybe over 70% of PAAs have some.
Right.
Thrombus alone might not be enough to trigger repair below 20 millimeters, but thrombus paired with impaired runoff seems to be a much better marker for identifying the higher risk PAAs, regardless of the exact diameter.
Because that poor runoff means any clot is more likely to cause major problems.
Exactly. It compromises the limb's ability to handle an embolic event.
Okay, let me try to summarize this section on screening and asymptomatic intervention. Make sure I've got it. First, screen every PAA patient for contralateral PAAs and AAAs. Use DUS, repeat every 5 years.
Correct. Grade 1B.
Then, for asymptomatic PAAs, elective repair is generally recommended at 20 millimeters or greater. That's also grade 1B.
Yeah.
But for higher-risk patients without thrombus, you can consider deferring until 30 millimeters. That's a weaker grade 2C suggestion.
Correct again. More room for clinical judgment there.
And crucially, don't ignore the smaller ones under 20 millimeters if they have thrombus and signs of embolism or poor runoff. Repair should be considered there too. Grade 2C again.
You've got it. That captures the nuances nicely.
Okay, great. Now let's apply this. Consider a 72-year-old male. He's got chronic heart failure, history of MI, and asymptomatic PAA is found, measures 28 millimeters.
Okay, close to that 30 millimeter mark.
Yes, and it has significant mural thrombus on the duplex.
Yes.
His life expectancy is estimated to be less than 5 years because of his comorbidities. What's the most appropriate management strategy here?
Right. This is a complex scenario. You've got an aneurysm approaching 30 millimeters with thrombus, which definitely increases the risk of complications. So intervention seems warranted based on the aneurysm characteristics.
Okay, intervention is likely needed.
Yes, but then you have his comorbidities and diminished life expectancy. So based on recommendation 4, which is a grade 2C recommendation, the guideline suggests that for patients with diminished life expectancy, if intervention is warranted, endovascular popliteal artery aneurysm repair, or EPR, should be considered.
EPR, the endovascular approach. Why?
Because it's generally a less taxing procedure physiologically, fewer major postoperative complications compared to open surgery. For this kind of high-risk patient profile, EPR is often preferred, irrespective of, say, saphenous vein availability or the quality of the runoff vessels.
So for this specific patient, the thrombus and size push towards intervention, but his overall health and life expectancy push towards the less invasive option, EPR.
Exactly. It's about balancing the aneurysm risk with the patient's overall surgical risk and long-term outlook.
That brings us perfectly to the next critical question then. How do we choose between open versus endovascular repair more generally?
Yeah.
And then how do we approach those really urgent, limb-threatening acute presentations?
Right. This choice between open, OP, and endovascular EPR, it really involves balancing several factors: the patient's risk profile, their life expectancy, and specific anatomical considerations. Okay. The guidelines, again, using a grade 2C recommendation, suggest that for asymptomatic patients who have a life expectancy of 5 years or more.
5 years or more?
Yes. And importantly, provided that an adequate single-segment great saphenous vein, GSV, is available,
Good vein needed.
then open PAA repair is generally suggested.
So, open repair, using a good vein graft for the healthier patients expected to live longer. What's the rationale there? Better long-term results.
That's the thinking, yes. While high-quality head-to-head trial data comparing the two is still scarce, several studies indicate better long-term outcomes after open repair. Specifically, superior patency rates and fewer major adverse limb events, especially when you use that good quality, great saphenous vein for the bypass.
And what constitutes an adequate vein?
It's generally extrapolated from peripheral arterial disease studies, usually greater than 3 millimeters in diameter, and free of significant stenosis or other issues. If you don't have a good single-segment GSV, you can use alternatives, like prosthetic grafts with acceptable outcomes, but vein is preferred.
Okay, so OPA with vein preferred for the good prognosis group. What about those with diminished life expectancy or higher surgical risk, like the case we just discussed?
Right. For those patients, particularly those with high cardiovascular risk or maybe adverse anatomical features like severe venous stasis disease, endovascular repair, EPR should be considered if intervention is indicated.
Same grade 2C recommendation.
Yes, also grade 2C. The advantage of EPR here is that it's less invasive, generally has fewer postoperative complications, so it's often seen as a safer option for these higher risk individuals, and the decision isn't as dependent on having a perfect saphenous vein or excellent runoff.
Does the quality of the runoff, the tibial vessels, play a role in choosing between open and endo?
It can. Some retrospective studies suggest that poor outflow might negatively affect EPR results more than OPR results. So for patients with poor tibial or pedal runoff, open repair with a good vein graft, if they're a good surgical candidate otherwise, might be considered preferential.
So it's complex. It sounds like there's no single right answer. It really depends on the individual patient picture.
That's absolutely right. The absence of really robust comparative data means that thoughtful judgment by an experienced vascular surgeon, considering all these factors, remains paramount in picking the best strategy for that specific patient.
Okay, that makes sense. Individualizing the approach based on the patient profile is key. Now let's switch gears slightly to those acute presentations, the patients arriving with acute limb ischemia, ALI. How do the guidelines help us stratify management for these critical, time-sensitive scenarios?
This is a really important area. The guidelines provide a strong grade 1B recommendation here. Intervention for thrombotic or embolic complications of a PAA needs to be stratified by the severity of the acute limb ischemia at presentation.
Stratify by severity. How do we measure that?
We use the Rutherford classification of acute limb ischemia.
Okay, Rutherford grades. What's the approach for the less severe cases?
For patients with mild to moderate ALI, that corresponds to Rutherford grade 1 and grade 2A if they also have severely obstructed tibiopetal arteries.
So bad runoff.
Yes, bad runoff documented. Then the recommendation is to consider thrombolysis or some form of pharmacomechanical intervention first. The goal is to improve that runoff status before you go to definitive PAA repair.
Trying to open up the distal vessels first.
Exactly. Restore patency in those tibial vessels to give your subsequent bypass graft or endovascular repair the best chance of success. However, it's important if arteriography shows only PAA thrombosis, but the inflow is good and the outflow target looks suitable.
Good runoff already present.
Right. Then aglytic therapy is not indicated. You should proceed directly to prompt surgical or endovascular reconstruction.
Okay, so lay this only if needed to improve poor runoff in milder ALI. What about the more severe cases?
For severe acute limb ischemia, that's Rutherford grade 2B, where the limb is immediately threatened but still viable.
Sensory and motor loss starting.
Yes, often diminished sensory and motor function. For these patients, prompt surgical or endovascular PAA repair should be undertaken immediately. No delay.
Why no lysis there?
Because these patients simply cannot tolerate the additional ischemic time that infusion thrombolysis would require. Time is absolutely critical.
So straight to revascularization for Rutherford 2B. Any other considerations?
Yes, adjunctive measures are key. You should actively use things like surgical thromboembolectomy or pharmacomechanical intervention during the revascularization procedure itself to maximize the tibiopetal outflow you achieve.
Get as much clot out as possible.
Exactly. And depending on how severe and how long the ischemia has been, you might also need to perform calf fasciotomies after successful revascularization to deal with compartment syndrome.
Right, compartment syndrome is a major risk after revascularizing these limbs. What about the worst-case scenario?
For non-viable limbs, that's Rutherford grade 3, the recommendation is primary amputation.
No attempt at revascularization.
No. Attempting to revascularize a non-viable limb carries significant risks: reperfusion injury, potential renal failure, systemic collapse. It's generally futile and dangerous. The timing of amputation is guided by the patient's clinical and physiologic status.
Okay, this stratification based on Rutherford grade is absolutely critical for limb salvage, it sounds like. Let's apply this again. A 55-year-old male presents. Sudden onset severe right lower extremity pain, pallor, paresthesias, pulselessness.
Classic signs.
He has diminished sensory and motor function in his foot, but no complete paralysis yet. On examination, you feel that pulsal popliteal mass. This presentation aligns pretty well with Rutherford grade 2B acute limb ischemia.
Agreed. Immediately threatened limb.
What is the immediate recommended intervention for this patient, and what adjunctive measures should be top of mind?
Okay, for this patient presenting with Rutherford grade 2B ALI from a PAA, the immediate recommended intervention, and this is that grade 1B recommendation, is prompt surgical or endovascular popliteal artery aneurysm repair.
Straight to repair.
Straight to repair. They cannot tolerate the time delay of infusion thrombolysis. And during that revascularization procedure, you absolutely need to consider adjunctive measures like surgical thromboembolectomy or pharmacomechanical intervention to maximize the tibiopetal outflow. Get those distal vessels as clear as possible.
Makes sense. Urgent repair plus active efforts to clear distal clot. Okay, this naturally raises an important question. Once a patient has undergone intervention for a PAA, whether open or endo, or maybe if they're one of those patients being monitored non-operatively, what is the long-term surveillance protocol? How do we follow these patients to ensure optimal outcomes and potential complications down the line?
Yeah, vigilance through structured follow-up is absolutely critical in both scenarios, treated and untreated PAAs, just given the ongoing risk of complications.
Okay, so let's start with post-repair follow-up. What do the guidelines say there?
For patients who've undergone either open popliteal artery repair or endovascular popliteal artery repair, the guidelines recommend a pretty robust follow-up schedule. It involves clinical examination, checking the ankle brachial index, or ABI, and doing a duplex ultrasound, DUS.
How often?
This should happen at 3 months, 6 months, and 12 months during that first post-operative year.
3, 6, 12 months, first year.
Correct. And if everything looks stable at the 1-year mark, then surveillance should continue annually thereafter. This is another strong recommendation, grade 1B.
Okay, annual checks after the first year, if stable. What are we specifically looking for in that DUS surveillance?
You're doing a couple of key things. First, you're evaluating the repair itself, looking for any graft-threatening lesions like stenoses, particularly at the anastomoses. These are a principal cause of graft thrombosis if missed.
Catching problems before the graft fails.
Exactly. And second, critically, you must thoroughly evaluate the original aneurysm sac for any evidence of enlargement on the DUS.
The BCHAC can still enlarge even after repair.
It can, especially after endovascular repair if there's an endoleak, perhaps from persistent flow through genicular branches feeding the sac.
Endoleaks. Okay.
So if any abnormalities are found on the clinical exam, the ABI, or the DUS, like a stenosis or sac enlargement, then appropriate clinical management needs to be undertaken, following the established lower extremity endovascular or open bypass guidelines.
Be proactive.
Very proactive. This is vital because retrospective reviews have shown a high incidence of secondary interventions needed after PAA repair, somewhere between 33 and 63% within the first 2 years.
Wow, that's a lot of reinterventions.
It is. It highlights the need for this close surveillance. DUS is really key to identifying those problems early.
What if the aneurysm sac does enlarge and starts causing problems, like compression symptoms?
Good question. If compressive symptoms develop, or if you note symptomatic aneurysm sac expansion, the guidelines suggest surgical decompression of the aneurysm sac. This is a grade 1C recommendation.
Grade 1C for decompression if needed.
Yes. An expanding sac after treatment is a documented risk factor for rupture, potentially due to those endoleaks we mentioned.
Okay. And what about medical therapy after repair? Any specific recommendations?
Well, continued atherosclerotic risk factor modification is definitely recommended. Smoking cessation, statins, managing blood pressure, and diabetes. And antiplatelet agents are generally advised.
Standard PAD management, basically.
Pretty much. It's largely extrapolated from peripheral arterial disease management, as specific data just for post-PAA repair is limited. There's some nuance in the data regarding anticoagulation for vein bypasses versus maybe dual antiplatelet therapy for prosthetic grafts, but standard risk factor modification and antiplatelets are the baseline.
Okay, so a structured follow-up with clinical exam, ABI, and DOS is definitely key for repaired PAAs. What about those asymptomatic PAs that aren't offered repair? Perhaps due to patient risk factors, or maybe the aneurysm is still small and doesn't meet criteria yet?
Yeah.
How do we monitor those patients?
Right. For that group, asymptomatic PAA patients who are not offered repair, the guidelines suggest, again, a grade 2C recommendation, that they should be monitored annually.
Annually. What does that monitoring involve?
It involves checking for any changes in their symptoms, doing a careful pulse examination, assessing the extent of any thrombus within the aneurysm via duplex ultrasound, checking the patency of the outflow arteries.
Looking at the runoff again.
Exactly. And, of course, measuring the aneurysm diameter to track any growth, all typically done with that annual DUS.
Why is this annual check so important if they were deemed okay for non-operative management initially?
Because the risk of complications isn't zero, and it increases significantly over time. Remember those stats. One study showed 24% developed complications within just 1 year.
24% in a year.
And a striking 68% developed complications within 5 years in that cohort of initially asymptomatic PAAs managed non-operatively.
Wow. So watchful waiting isn't passive waiting.
Absolutely not. Another report indicated complications occurred at a mean of 18 months, and frighteningly, The amputation rate was 25% for those patients who experienced complications.
A 25% amputation rate if complications occur.
It underscores the danger. And it's crucial to remember that even aneurysms less than 20 millimeters in diameter have been shown to cause complications sometimes. So, like most aneurysms, PAAs can definitely lead to limb loss if you don't maintain a high index of suspicion with regular serial surveillance.
Okay, so rigorous annual D-West surveillance is essential for the unrepaired group. Let's consider this final scenario then. A patient undergoes a successful open popliteal artery aneurysm repair with a saphenous vein bypass graft. 3 months post-operation, routine duplex ultrasound reveals a new, significant stenosis right at the distal anastomosis. The patient feels fine, totally asymptomatic.
Okay, a common scenario found on surveillance.
What is the recommended next step in management based on the SVS guidelines?
The recommended next step here, based on that Grade 1B follow-up guideline, is to undertake appropriate clinical management according to the established lower extremity endovascular or open bypass guidelines for dealing with graft stenosis.
So, intervene on the stenosis even though the patient is asymptomatic?
Generally, yes. Identifying and repairing these kinds of graft-threatening lesions, even if the patient feels fine, is considered critical. The goal is to prolong the bypass patency and prevent future complications, specifically graft thrombosis and subsequent limb loss, which are unfortunately common if significant stenosis are left unaddressed.
Proactive intervention to save the graft in the limb.
Precisely. That's the core principle of the surveillance strategy.
This whole deep dive into the SVS clinical practice guidelines on popliteal artery aneurysms has been incredibly insightful. We've really covered the whole spectrum, haven't we? From the fundamental definitions and natural history, right through to the intricate decision-making for intervention, handling acute limb ischemia, and that crucial long-term surveillance.
We have indeed. And while these guidelines absolutely represent the most salient, evidence-based recommendations currently available, it is important for everyone listening to remember that in the management of PAAs, there's still, frankly, a dearth of high-quality evidence in some areas, particularly from large randomized controlled trials.
Still gaps in the evidence base.
There are, and this really highlights the ongoing need for rigorous, well-controlled studies to establish further clarity in this specific clinical area. So what this means in practice is that experienced clinicians still retain considerable latitude in their approach.
So it's about blending the guidelines with experience.
Exactly. Blending these guidelines with clinical expertise, individual patient factors, anatomical considerations, it's still very much an art as well as a science.
Yeah, what really stands out to me, reflecting on this deep dive, is exactly that the balance between these established best practices from the guidelines and the evolving nature of our understanding in complex conditions like PAAs. For you, the listener, we definitely encourage you to consult the full Society for Vascular Surgery guidelines for their complete context and all the supporting detail.
Absolutely essential reading.
And of course, to continue applying critical thinking and that blend of evidence and experience in your own practice. Thank you so much for joining us on this deep dive.